Hi and welcome to the White Army. I'm Dr. Aditya Nimbkar. I am working as an assistant professor in SAIT GS Medical College and KM Hospital in the Department of OBGY, Mumbai. And today I'm here to talk about a topic which, in my experience as a faculty in a government college and as a student earlier, I had found a great deal of difficulty, a great amount of difficulty while working around this topic or while implementing this topic in my practice. So the topic, as you all have already read about, is going to be partograph. And partograph, it's a word that is made up of two words, parto, which stands for parturition, and graph, which stands for a diagram. So it's a diagram of the parturition or the process of labor that you make. A very useful thing, and more than useful, it carries a lot of medical legal significance. So it is something that can save you from a lot of lawsuits, whereas its absence can land you up in a soup, and that can be very difficult to get out of. So Partograph, although a lot of people don't follow it, it is a good thing. It's a great thing if you have implemented it in your practice, if you're able to work your way around it, and if you're comfortable plotting it. But if not, today the session is going to be on every single thing, every single evolution that this partography has undergone over the last 70 years. So first of all, when I talk about partograph, the first ever partograph was made by someone called as Fredman, and it was made in the year 1954. This was the first partograph that was made, and it was a very simple partograph. Later on, the simplicity was so much that it was slightly upgraded, and the WHO, that is the World Health Organization, in the year 1990 decided to come up with its own first set of parthographs, and they were called as the composite parthographs. I have images of all these parthographs. I'll be showing them to you later. But the first one that they had was called as a composite partograph. I'm just using a short form of PG. Later on, it was modified. Why were the modifications done? What were the modifications? Every single thing I'm going to be talking about. But before that, I'm just giving you a description. I'm just giving you a start as to how and what's the evolution been like for phytographs. Then the year 1994, they modified it a bit and then they decided to call it the modified partograph. But then they started realizing as good and useful it is, the understanding of the partograph is a little difficult, especially for people who work at lower centers and people who are not obstetricians but are delivering babies in lower centers. So they decided that we'll simplify it a bit in the year 2000 and they decided to call it the simplified partograph. Eventually, this became a routine practice, either the modified or the simplified one, more so the modified partograph. But as the understanding of labor improved, 20 years later, that is in the year 2020, the WHO released the Labor Care Guide. The Labor Care Guide was a completely upgraded version of Partograph, which is the recent most update. Unfortunately, it is a very good thing, but is still not being implemented by a lot of people. We are going to be talking about each and every single modification and each and every single partograph, but these are the four partographs as you can see. First of all, I would like to show you the images before coming back to them to describe what were the changes. So the images, this first of all is the composite partograph that was released in the year 1990. Then this was the modified partograph. I'll come back to explaining after a while, but before that, let me just show you this was a modified partograph. Then this was a simplified partograph. And finally, the latest update that happens to be my Labor Care Guide, LCG, WHO Labor Care Guide, which was released in the year 2020. So this is the latest and the youngest sibling of all the four, the senior most being the composite partograph. I'll come back to this later, but before coming to partographs, let me just talk about Parto first. Parto is parturition. So just a bit of brush up for what is labor and how does it progress. So when I talk about labor, I have to remember that the labor is going to have four stages. The first stage is going to have my latent and active stage. Now, what is first stage of labor? So, first stage of labor is from the onset of pain till full dilatation of my cervix. That is full 10 centimeters dilatation of the cervix, or what you can also say is till the delivery of the head of the fetus. Second stage is going to be from the point of full dilatation to the delivery of the baby or to the delivery of the head. My bad, in the first stage it is just till the full dilatation, whereas the second stage is from the full dilatation to the delivery of the head or the delivery of the fetus. The third stage is delivery of the placenta, and the fourth stage is going to be the puerperal period, that is the next 6 weeks after deliveries, wherein the female's body is recovering, she is into the lactation phase, and her body, her uterus is involuting, her body, the changes, the physiological changes that have shown up in pregnancy, or the pathologies that have shown up in pregnancy, like preeclampsia or gestational diabetes mellitus, all of them start reverting back. So that is the fourth phase, that is the recovery phase of the body. So the partograph is going to deal with the first and second stage. The second stage of labor, that is from full dilatation of the cervix to the delivery of the fetal head or the fetus, is only incorporated in the latest labor care guidelines. So until then, the first three types, that is a composite, modified, and simplified, were having or were only catering to the first stage of labor. In first stage, I have latent and active labor. Now you would say, what is latent and active labor? And our old understanding and a comfortable understanding has been that latent labor is from 0 to 4 centimeters dilatation of the cervix, whereas from 4 to 10 centimeters is active labor. Now, this is an old understanding. There are several reasons to it. The reasons are that people have realized that the labor, why was it called as latent labor in first place? Why was 0 to 4 called as latent labor? The reason was that labor progressed very tardily, very slowly in these first 4 centimeters, and there was no end limit to it. Like, studies had shown that it can take even 2 to 3 days for labor to progress from 0 to 4 centimeters. Occasionally, a patient would be 1 or 2 centimeters dilated for even a week or more. So they said that there is no end limit to it, and hence the latent labor is from 0 to 4 centimeters, whereas after 4 centimeters, the labor progressed rapidly. Now, these are the older studies. The older studies said that from 4 to 10 centimeters, the labor progressed rapidly, and there was a finite amount of time in which the baby now had to deliver. Because if it didn't deliver in that finite amount of time, then it was suggestive of protracted, yani slow labor, or it was an indication of arrested, that is completely halted labor. I'll be coming to all these terms later on. But now the newer understanding is that these things are completely wrong to understand, and the latest understanding can only be understood when I will be showing you the labor care guide. Although there has been an intermittent understanding as well, wherein it was said that the latent labor is going to be until 5 to 6 centimeters of dilatation, and after 5 to 6, I'm not saying 5, I'm not saying 6, they're saying 5 to 6. So, as an arbitrary thing, a lot of people even said 6 centimeters. So, they said that the latency was until 5 to 6 centimeters, and the active phase, wherein the labor progressed rapidly, was only after 5 to 6 centimeters. So, this was an intermittent understanding, but the newer understanding is only going to be understood when I show you the labor care guide. But that is going to be the last part of this session when I come to labor care guide. Before that, I had mentioned a few words. I'll be talking about what are they. So, labor, when it progresses well, is a great thing. But labor, when it doesn't progress well, or what we also call as dysfunctional labor, the word is called as labor dystocia. This dystocia can be of two types. It can either be prolonged labor, or what we also call as the protracted labor. The word for it, the official word is protracted labor. Or there can be completely halted or stop ho chuka hai progression, what we also call as arrest of labor. It is very much like whenever a person is getting arrested and put into jail, the person's activities, all the miscreants, their illicit activities are going to be halted by the police. They are going to be completely stopped. So arrest of labor is when the labor is stopped completely. There is no dilatation, there is no descent of the head. Everything is stopped completely. So obviously, both of these can happen in the first and second stage of labor. So basically, there can be prolongation of first stage of labor. First stage of labor is going to be my stage from initiation of labor activity or labor pains till full dilatation, or second stage, which is from full dilatation to the delivery of the baby's head. The same thing can occur with arrest of labor. That is, the labor can be completely halted either during dilatation or after complete dilatation before the baby is delivered. So it is going to be a term that is common for both the stages of labor. But why should this happen in first place? So the causes of labor dystocia can be maternal, fetal, and most importantly, maternal plus fetal. So when I talk about the maternal factors, before talking about it, I have to tell you a bit of anatomy. Now, when I talk about the anatomy, this is my uterus, this is my fallopian tube. Okay, so I'm not drawing the femora and ovaries because that is not important over here. So now you have to know that this point that you see is called as the cornua. This cornua is the point where the uterine musculature converts or gets shifted to form the fallopian tube. So it is a junction between the fallopian tubes and the uterus. But it's a very important place because this is also called as the pacemaker, or rather than pacemaker, the activity controller of the uterus. What it means is that these are the 2 points in the uterus where the contractions are generated. So basically, if this is my arbitrary or just an imaginary midline, then the activity is going to be initiated in this direction from this point. Similarly, from here as well, it is going to be generated from this direction towards the center. And similarly, when there is relaxation, it is going to be in the reverse direction. Now, the point of this activity coming from both the ends, if this is my uterus and if it is coming from both the ends, is that the baby has to be pushed to the center. So basically, the baby which is lying completely is going to be compressed and is going to be made into a complete longitudinal baby. So the contractions will first of all make the baby completely longitudinal, and after making it longitudinal, they will push the baby downwards. So the baby is going to be pushed continually downwards, and as the baby keeps going downwards, the uterus keeps contracting further. So basically, the uterine size also gradually reduces so that the baby doesn't come back upwards. So the point of these 2 points is to generate those contractions which will make the baby come to the center, and then it's going to be pushed downwards. This is how my normal labor progresses. Now, there can be two problems in this, and those are the two problems that can occur in the maternal cause of labor dystocia. One is either the contractions are not adequate enough. So, hypotonia. Hypotonia means either the number of contractions, the number of contractions is low, or the strength of contractions is low. Either of these two things can happen. So uterine hypotonia is going to be one of the causes. The treatment is obviously that I have to increase the number of contractions and the strength of contractions. That can be done by amniotomy. Amniotomy is basically artificial rupture of membranes. Because once I do artificial rupture of membranes, prostaglandins, endogenous prostaglandins are going to be released. And once they are released, I have to know that they will start acting on the uterus and they will increase the number, I mean the frequency and as well as the strength of contractions. The second option is I can start the patient on oxytocin, a uterotonic, so that the contractions increase by a drug that is oxytocin. So this is for hypertonia. The other thing that can happen is from one side there are very strong number of contractions, whereas from the other side, they are not yet that adequate. There are only one or two contractions. This is just a depiction. So they are not strong enough. This will lead to uterine dyssynergia. What is dyssynergia? There are several contractile forces from one end, but from here there are only a few that are coming. What will this do? This will push the baby to one side. That longitudinal lie is not going to be generated. Plus the uterus is not going to be effectively able to push the baby downwards. This is called as hypertonic labor dystocia or uterine dyssynergia. This is also called as hypertonic uterine dysfunction. Because the tone is adequate, the number of contractions are also adequate, but they are not complemented enough. It can also so happen that one of them is coming from this direction, whereas the other one is pointing towards the another. So the direction of the contractions is not cancelling on each other, and hence, because of this, one is pressing the baby here, the other one is pressing here. There is no synergy in between them, and even that can lead to dysfunctional labor. The treatment to this is going to be to, in fact, take the patient for cesarean section, or to maybe just stop this labor completely and give the uterus another chance to restart it. So I'll give a uterolytic agent or a tocolytic agent that we call as, the treatment will be terbutaline. Terbutaline will help me stop all the contractions at once, and it's a beta mimetic. It will stop, it will halt all the contractions, and then I'll start the patient on oxytocin, and then I'll see whether the dyssynergy has gone and now the uterus is contracting uniformly. So basically, I'll give a tocolytic that will end all the contractions, and then I'll start the patient after some time on oxytocin to see whether now the dyssynergy has gone completely. That is how I'll be treating. Just a small error. This is going to be the treatment for dyssynergia. Yeah, terbutaline or even nifedipine or calcium channel blocker. Any of these can be given. So this was about the maternal factors. What about the fetal factors? The fetal factors can be plenty. It can be something like macrosomia, that the baby is too big for that pelvis, or there can be a malpresentation. A malpresentation, it can be a breach or a transverse lie, or it can be a malposition. A malposition, I intend to say, it can be occipito-posterior, which will still deliver, but it will find it longer to deliver, or occipito-transverse, wherein the baby is not going to be delivered unless the baby is very small in size. So these are the various possibilities. And of course, if there are any malformations, any congenital malformations like hydrocephalus or a large sacrococcygeal teratoma, all these things, all these malformations which increase the baby's particular size, particular dimension of that baby, that is going to obstruct the labor. What about a combination? So combination of them is going to be something like cephalopelvic disproportion, that the baby is of okay size, but the maternal pelvis is not adequate, or a contracted pelvis. Contracted is basically the bony pelvis is completely small. And if the baby would have been preterm or very small, then it could have delivered. But if the baby is a full term, normal size, normal weight way baby, it is not going to deliver. So both the maternal and fetal factors are going to be commonly involved. So these are the commonest causes of labor dystocia that you all need to know of. Okay. So now that I've spoken about labor dystocia, I need to know, how do I diagnose it? How do I know whether this is there is dystocia? How do I know whether this is prolongation? How do I know whether there is arrest or not? So the diagnosis of labor dystocia is the next topic. So how do I diagnose it? So first of all, in the first stage of labor. So in the first stage, the first part that I'm going to be talking about is latent labor. Now, latent labor is a very tricky phase. I mean, in latent labor, you do not really give those terms like prolonged labor or arrest of labor, because latent is meant to be prolonged. Latent phase is known to be latent, which is slow phase. So in that case, they have still given a definition which varies. Of course, all the definitions, by the way, vary for primigravidas and multigravidas. The reason is that multigravid uteri are a lot more responsive and are a lot more roomy, so they allow the fetus to go down much more rapidly, where in comparison to primigravidas. So although it is not really followed, but Williams 26th edition does define latent labor to be prolonged if it is going to last for more than 20 hours, whereas multigravidas, if it is going to last for more than 14 hours. Although this is not a strictly followed definition, and if at all you have to do anything, if it is more than this, then what you will do is amniotomy. Amniotomy is, you will rupture the membranes after fixing the head. But do not preferably take these patients for cesarean section, because latent labor is always going to be slower than your active labor. So this is for prolongation. There is no such thing as arrest of latent labor. Then the next is going to be active phase or active labor. Now, in active labor, There are two ways in which I can assess my progress of labor. Remember, there are two components to labor. One is the mother and the other one is the fetus. So the maternal component is going to be her cervix, which is going to dilate. Whereas the fetal component is going to be the fetal head that is coming down, which we call as a fetal descent. So both have to progress hand in hand in tandem for us to be able to deliver the baby successfully. We cannot have that the dilatation is occurring, but the baby is not progressing, or the baby is progressing, the baby's head is coming down, but the cervix is not dilating. We need both of them to go hand in hand. So we have two different definitions for them. So for the first one, for prolongation, we have first of all for descent, and the second one is going to be for dilatation. So now, how do we know about dilatation? Of course, we do a per vaginal examination and we try to assess with my middle finger and my index finger how much is the dilatation. Now, it's a thing of experience. You do not just take a tape and you keep it and you measure it. It is a thing of your experience that you know that if this is this much, then it is 4 centimeters. If it is this much, it is 8 centimeters. It's a thing that comes with experience. Whereas descent is something that is specified very classically on the basis of your ischial spine. So whenever you do a per vaginal examination on the lateral pelvic wall at around 5 o'clock and 7 o'clock position, you will feel two bony prominences. Those are called as ischial spines. If they are felt very easily, then it's an indication of mid pelvis CPD. But if it is not felt easily and you find some difficulty in finding them, that's a good thing because it will indicate that the mid pelvis is adequate. So whenever you go and try to touch them, if your fetal head is at this position and if your spines are below that, then it indicates that your station is above the spines and your descent is going to be said in terms of -1, -2, -3, -4, -5. Whereas if it is at the level of those spines, then your station is going to be 0. The descent is going to be at 0 level. Whereas if it is below that, then it is going to be +1, +2, +3, +4, and +5. +5 is at the level of perineum, wherein the baby's head is going to start crowning. So I have to see whether the fetal head, which was here at this point, after 2 hours or 4 hours, has come down to any other level. This is called as descent. So descent is going to be calculated in terms of +1, like let's assume it has come from -2 to 0. So the descent has happened by 2 centimeters, that is -1 to 0. Whereas the dilatation is going to be spoken in terms of 0 centimeters to 10 centimeters. So for primigravidas, which is my first column, the prolongation is going to be spoken of for descent if it is less than 1 centimeter per hour over the last 4 hours, or for multigravida if it is less than 1.2 centimeters per hour. For dilatation, the same values are if it is less than 1.2 centimeters per hour or less than 1.5 centimeters per hour. Now this is your now these are all your per vaginal examination findings. You do not do a PV examination every hour to find it out. You will be doing a per vaginal examination as per guidelines every 4 hours. But there are a few institutions which prefer to do it even after 2 hours, but not less than 2 hours definitely during your first stage of labor. So when you're doing this PV examination, you will be counting. So if it is a per vaginal examination that is done after 2 hours, then you'll be seeing that the descent has to be more than for a primary gravida, more than 2 centimeters over the last 2 hours. So you have to calculate it as per the total amount of time that has elapsed since your last per vaginal examination. If there is prolongation of labor, your treatment is going to be amniotomy, that is your artificial rupture of membranes, or you will start the patient on oxytocin. So this is for prolongation. Whereas if there is arrest of labor, the definition is going to be for arrest. It can either be a primary arrest or it can be a secondary arrest. Primary is when there was no dilatation that had ever occurred before, and directly the baby has never progressed at all. Whereas secondary is going to be when the baby did have the cervix did have dilatation before, but now it has stopped dilating. So primary is going to be without any prior dilatation. Secondary is after prior dilatation. So for primary, for both primies and multigravidas, it is more than 2 hours without any dilatation. Whereas for secondary, it is going to be if 4 hours with contractions, with adequate contractions, or 6 hours without adequate contractions. I mean, the patient is just not getting adequate contractions despite oxytocin being started. So that is how you will be defining arrest for primary and multigravida, both of them. Now, this was about first stage of labor. For second stage of labor, it is much easier. In second stage, for primary gravida, it is you have to wait for 2 hours. So if for 2 hours there is no descent in a primary gravida, or more than 1 hour without no descent, because the dilatation is already done, so there cannot be any further dilatation. Now what has to happen is the head has to descend. Remember, your second stage is from full dilatation of the cervix to the descent of the head or to the delivery of the head. So if more than 2 hours there is no descent, or if 1 hour for a multigravida if there is no descent, we call this second stage arrest of labor. Remember, there is a difference between secondary arrest of labor and second stage arrest of labor. Secondary arrest is in your first stage of labor, whereas second stage arrest is happening in your second stage. So these are the various definitions of your labor dystocia. If you want, you can take a screenshot of this, which will help you know how to diagnose your labor dystocia. Now, these findings are all of what do I say? These findings are all, or rather, these diagnostic points are all those that have been given in Williams, the latest edition in the chapter of labor. So this is my source. Now, since you have taken a screenshot, now I'll be going towards a few examples and shall be explaining you how to chart a partograph. Now, when you see this composite partograph, this was the first ever proper partograph that was made by WHO in the year 1990. Now, in this, you have to see that there are a few important components. The most important is the name. Name, very important, because you do not want your labor chart of one patient to be misplaced with the other one, or to be misplaced in the file of the other patient, because that can be, of course, you can end up giving a wrong decision. Secondly, is going to be your gravida and parity status, because of course, just now we have seen that the definitions vary for multigravida and primary gravida. The use of writing this is also so that whenever your duty is over, remember, these labor patients can take more than 24 hours. So if your duty is going to end after 12 hours or 24 hours, when you're giving the patients over to the next team that is going to manage the patient, you need to have everything clear so that they'll be able to look at the chart and be able to assess, because you cannot be mentioning them what all has happened over the last 24 hours. You cannot be just mentioning it to them in detail. That is going to be a very tardy thing, and when more so when you have multiple patients who are in labor. So instead, this chart is going to give them a fair bit of idea of what is the patient's current status. So gravity and parity, of course, very important, so that you can determine how long to wait before you call them prolongation or protracted labor or arrest of labor. Next, you have to insert your hospital number, which is basically your admission number, the patient's unique ID, then the date of admission, so that you know when this patient has probably been in labor, then the time of admission, of course, and if the membranes have been ruptured, and if yes, then when have they been ruptured. So you have to write the time over here. So you have to write it in hours of, like, basically how many hours since she has been ruptured, or rather than hours, you can just write when was the rupture of membranes, whether it was spontaneous or whether you did it as an artificial rupture of membranes. So these are the things that you have to fill in it. Next, you had the fetal heart rate. Now, fetal heart rate, how often do you monitor it? Now, fetal heart rate for a low risk patient and for a high risk patient has different criteria. उसमें भी in a low risk patient in the first stage and second stage it is different. Similarly, for high risk in the first stage and second stage it is different. So, for a low risk patient, what is the meaning of low and high risk? Low and high risk means there is, if I'm talking about a low risk patient, then there are absolutely no risk factors. What are the risk factors? They can be maternal risk factors like preeclampsia, gestational hypertension, or something like abruptio placentae, or severe anemia. Or there can be fetal high risk factors like small for gestational age, fetal growth restriction, twin gestations, all these things. So if there are no such risk factors, then in that scenario, the patient is going to be a low risk patient. In that scenario, you will be looking at or ausculting her heart rate every 30 minutes. Whereas in the second stage, it will be done every 15 minutes. Whereas if the patient is having any of these maternal or fetal high risk factors, then in the first stage, it is going to be 15 minutes. And in the second stage, it is going to be every 5 minutes. This is called as intermittent auscultation. Now, this intermittent auscultation, you remember, yeah, intermittent auscultation is the second best thing to do. The best thing to do is if you have a machine, the cardiotocography machine, then you just attach it to the patient. You do not need to do that for a low risk patient, but for a high risk patient, it is always recommended that you use, instead of going and checking every 15 minutes, you just attach that cardiotocography machine, which will keep a continuous monitoring of your fetal heart rates. In proper tertiary or quaternary care hospitals, there are now computerized CTG machines wherein you can just sit in a room and you can have all of them, all the CTGs accumulated and being shown to you on your screen together. And if there is any problem, if there is any dysfunction in the heart rate or in the uterine activity, it will be immediately reflected. That is also called a CCTG, that is computerized CTG. That is expensive, but is often done in most private hospitals now. But if you are in a resource limited setting like a civil hospital, then in that scenario, you will be resorting to intermittent auscultation with your handheld Doppler. In labor, do not prefer using the stethoscope because you cannot calculate or count how many heart rate is, how much of heart rate is there. So always use a Doppler which shows a reading. So every 30 minutes or 15 minutes or 15 minutes and 5 minutes, depending on whether it is first or second stage and whether your patient is low or high risk. According to that, over here, you will be charting. This is the normal range. The normal range is going to be between 110 to 160 beats per minute. And you will be charting it. So let us see that the labor started at 130 beats per minute. Then it was 140. Then it was again 130. Then it was at 120. So this is how you'll be charting a graph like this. So it will keep on going like this. Of course, anything that goes above this, that is fetal tachycardia, or anything that goes below this is a bad thing, and I would want to immediately look into it. The baby is having distress. So in between this bracket, it is all good. The next thing that I have over here is liquor or liquor, whatever you call it. So liquor is your amniotic fluid. So when you talk about liquor, your liquor can either be, first of all, your membranes can be intact or they can be ruptured. So in this box over here that you can see, in this box, you will be writing that whether it is ruptured or not ruptured for pehle to baat. If it is ruptured, then you have to also write what is the type of rupture. Your type of rupture can be either a clear fluid, clear is the liquor is not stained with anything, it is clear straw colored fluid, or it can be meconium stained. When I talk of meconium stained, it will have three grades: grade 1, grade 2, grade 3, or what we also call as thin, moderate, and thick meconium. Thick meconium is going to be a bad thing. I have to immediately take the patient for cesarean section. Unless the patient is already in second stage of labor and she is delivering and there is no distress, only then you can wait. But for thick meconium, and a lot of hospitals even prefer to do that for moderate meconium, you will be taking the patient for cesarean section. So this is the grading. For that, you will be mentioning it as M. The box over here, you will be mentioning what is the liquor color every time you do a per vaginal examination. Apart from that, just before I proceed, see here that there are R's that are mentioned over here. You can see on this graph R's. So I prefer to do per vaginal examination every 4 hours. So if I've done an examination at 0 hours, that is on admission, then the next is going to be at 4 hours. So my liquor is going to be marked at the first point over here. I'll write whether it is clear or not. Then I'll be writing it over here at this point. So basically, I do not need to fill each and every box. I only need to fill it whenever I do a per vaginal examination. Yeah. Then the next possibility of a liquor can be if there is abruptio placentae and you're waiting for a rapid vaginal delivery, or if it's an IUFD. So abruptio is going to be A, or you can also write it as blood stained B. And yeah, so these are your major things. that you can write. Of course, if there is absolutely no liker demonstrable, then you can also write as no liker, that is N possibility, or absent liker is one more thing that you can write. So these are your various types of liker colors that you can have once your membranes have been ruptured, and you will be writing it every time you do a pervaginal examination. Over here, as you can again see, the timing has been mentioned. So you are sorry, where is it? Yeah, you have mentioned the timing. So according to the time, you will be writing it. The next column is about molding. Now, what is molding? Molding is basically an adaptation by the fetal head for it to be able to deliver through the vagina. So if this is my fetal head diameter, these are my two frontal bones, these are my two occipital bones, and these are my two parietal bones. So this is a rough diagram. It is the head doesn't look this bad, but so that it can accommodate in the bony pelvis, these bones often come together and they make a smaller diameter. For that, they do something called as molding. This is called as molding. Molding is basically they override each other. Now, the more the overriding, the more it is indicative of a cephalopelvic disproportion, the more it is telling me that possibly there is some obstruction that is occurring. So there are going to be three grades for it, or rather four grades. Zero, wherein I know that there is absolutely no molding. Grade 1 molding, wherein I know that there is molding, the bones, the parietal bones are touching each other, but they are just touching, they are not overriding each other, they are just touching. Grade 2 is when they are overriding each other, when they are basically placed on the top of each other, but the moment I do a per vaginal examination, they are able to separate and they are able to go away. So on manual touching and manual separation, they are able to separate. That is grade 2. And grade 3 is when they are riding each other and I'm unable to separate them. Grade 3 molding is indicative of definite CPD and that the baby may not deliver and you may have to take the baby for cesarean section. Till grade 2, it is still okay. So these are the grades of molding, and that is what you have to write over here in your molding, in your molding, marker highlighter here, in your molding segment over here. Yes. So in this molding segment, is this is what you'll be writing. What is the grade of your molding? Okay. So this was about the fetus. Now coming to the maternal side of things. So when I talk about the maternal side of things, first things that I'll be looking over here are going to be that I see that the cervix in centimeters is given over here. So it starts from 0 and it goes up to 10 centimeters, of course. Apart from that, there is also something called as descent of head that is given over here. I'll tell you everything about it. Now, this is the part wherein the modified partograph is different from my composite partograph. You see that there is a latent phase that is given over here, and that latent phase has lasted for 8 hours. This latent phase you can see has lasted for 10 hours, starting from 0 to 10. Sorry, 0 to 8. So 8 hours it has lasted. Now, this was indicative that your latent labor cannot last more than 8 hours, because if it lasts more than 8 hours, then it is possibly going to cross your alert line. You can see that there are things like alert line and action line over here. Now, these action line and alert lines were given by Philpott and Castle. Philpott and Castle, I'll just write the names if you want. Not really important. It's okay, just remember Philpott and Castle. They said that whenever anything is crossing the alert line, you have to call a senior consultant obstetrician and you have to reassess that we need to do something, or at least we need to intensify monitoring. There is a doubt, there's a suspicion that there might be labor dystocia. Whereas once it crosses action line, I have to definitely take an action, and that action will either have to be augmentation with oxytocin or a cesarean section. So these are the two very important lines. Now, as we all know that latent labor can go on for several days. But unfortunately, this composite partograph was saying that if it goes on for any longer than 8 hours, then it crosses the alert line. And if it goes on for more than 12 hours, because you can see that at 12 hours, your alert line starts. So if it crosses this line, that is called as the action line, then it is indicative that you have to do something about it. So unnecessarily, the interventions like oxytocin augmentation followed by cesarean section were increasing because of this partograph, which is why the latent labor that they're specified should be less than 8 hours and preferably definitely less than 12 hours were flawed. This was a flaw in this composite partograph because it was telling me that the latent labor has to be finite, which is not the case. The latent labor can go on for several days and you do not need to do anything about it, which is why when we see this modified partograph, you can see that this alert line and action line immediately starts at 4 centimeter, which indicates that there is no scope for latent labor. There is no space for latent labor in this modified partograph, which came 4 years after my composite partograph. You can see that the alert line is starting here at 4 centimeters. So it means that the latent labor is not considered, and they have said that your patient can be in latent labor as long as it wants to be in that. This was a major modification and it significantly reduced the number of interventions, unnecessary interventions, and cesarean sections for patients. So now, cervical dilatation, how do I chart it? I'll just erase all this. Yeah. So when I talk about cervical, you can see that they have mentioned that cervix has to be plotted as an X and descent of head has to be plotted like O. O, which resembles a circle, that is the fetal head, and X for the cervix. So the first thing is they said that whenever a patient would come to your hospital, the first thing that you will do is you will mark the time at which the patient has come. So let us see that the patient has come to me at 8 a.m. So I write over here 8 a.m. So this stands for 9, this is for 10, this is 11, 12, and so on and so forth. So that is the first thing that I would do. Then when the patient comes to me, I will plot at what is the dilatation. So I will plot X. X is going to be for my cervical dilatation. Then when I repeat the assessment after 4 hours, then I'm going to plot the next dilatation, which is let's say 6 centimeters. ऐसे ऐसे मैं plot करते जाऊंगा till it reaches 10 centimeter, which is basically the delivery, that is full dilatation of the feet of the cervical of the cervix. So this is how I'll be plotting. Whereas I'll be plotting the descent of head once the head gets engaged. How do I plot it? Remember that this is given from 0 to 5. So I have to consider it the other way around. So this has to be considered as 0, 1, 2, 3, 4, and 5. So how do I plot it? So once the patient has come to me, once the head crosses the ischial spine, that is the level of 0, then let us assume that it crossed the level of 0 at 6 centimeters. So I'll plot a 0 over here. Then after 4 hours, I repeated the examination and it had delivered. So it was over here at station is plus 5. You see that I've written 5 over here. So this is how I'll be plotting the graph. So this is the head descent and the earlier one was the cervical dilatation. This is how I'll be using this side of the partograph. And all over here, I'll be writing my timings. After that comes the contractions. How many contractions per 10 minutes? Now, there's a specific way of mentioning it. So, if the contractions are lasting for less than 20 seconds, then I'll be putting dots. If they are lasting between 20 to 40 seconds, then I'll be plotting it in the form of these lines. Whereas if they are more than 40 seconds, then I'll be making it completely solid color essay. So if this is my box, this is how it will look like. The ideal contractions or the adequate contractions are 3 to 4 contractions in 10 minutes lasting for 40 to 50 seconds. These are adequate contractions. Anything less than 3 contractions is said to be hypotonia. Similarly, any contraction that lasts less than 20 seconds is again hypotonia. Whereas on the other side, any contraction that lasts more than 4, that is for 5 contractions or more, is said to be hypostimulation. Similarly, any contraction that lasts for more than 50 seconds, that is 60 seconds, that is 1 minute or more, is said to be hypostimulation again. So in a period of 10 minutes, there should be 3 to 4 contractions, each which lasts up to 40 to 50 seconds. Nothing more, nothing less. So how do I plot it? So the first thing was, the first contraction that I was getting was, let's say initial in the labor, I was getting just 1 or 2 contractions. So in that 1 or 2 contractions, they were all lasting for less than 20 seconds. So I just made dots. After that, the contractions increased to 3 by 10 by 20 to 30. So in that scenario, I started making these lines because the contractions are now lasting for 30 seconds and they are 3 in a minute. Whereas in later on stages, it became a lot more wherein they were lasting for more than 40 seconds and they were 4 in number. So I started coloring this completely like this. So this is how I'll be charting the total number of contractions are mentioned over here. The timing is indicated by the type of box filling that you're doing, and that is what is going to give me an indicator. So of course, if it is continuously dotted like this, then I have to understand that it is too low. I have to start the patient on oxytocin, or at least I have to do amniotomy. Similarly, if it is more than 40 seconds, if it is reaching 60 seconds, then I have to give the patient a tocolytic so that hyperstimulation can be controlled, like terbutaline or nifedipine. The ideal is going to be this between 20 to 40 seconds, or at least between 40 to 50 seconds. That is the best. But even this 20 to 40 seconds is an okayish parameter. Less than that, that is less than 20, is not good. More than 50, it's not good again. So this is how the contractions are going to be charted. So once I chart the contractions, if it is occurring spontaneously without oxytocin, then I don't need to do anything more. But if it is with oxytocin, then I'll be writing the dose of oxytocin that I'm giving. So the dose of oxytocin for a primary gravida is 5 units that we put in 500 ml of RL, that is ringer lactate or normal saline, and it is started at 8 drops per minute, and then it is titrated to 8, 16, 24, 32, 40, 48. So we titrate it accordingly. So I'll be writing the dose of oxytocin that I'm going to give in the first box, and in the second box I'm going to write the drops that I'm giving per minute. This is how I'll be filling this segment of my partograph. After that, I'll be coming over here to write about the drugs that have been given. If the patient is a hypertensive, then labetalol, nifedipine that has been given, or magnesium sulfate if she is a severe preeclamptic or an eclamptic, or if she is receiving insulin, then I'll be writing everything in these boxes over here. The drugs that she has received in labor. If it is just normal saline or oxytocin, you just mention oxytocin and normal saline. After that, now this is a segment for maternal well-being. I'll be looking at the pulse and blood pressure. So when I look at the pulse and blood pressure, for pulse, I have to make a dot. You see that pulse is with a dot, whereas BP is with this way. How do I mark it? So the pulse, I have to mark, the pulse was, let's say, 75. So I made a dot over here. Then it was 90, was 85. उसके बाद में it was around 70. So this is how I'll be charting. And this is how I'll be drawing the line. Whereas the blood pressure, I have to draw in the form of a vertical line. So once it was 80 by 120 by 80, then I'll be drawing it like this, 120 by 80. Similarly, later on it became 130 by 90, then it will be 130 by 90. She became a hypertensive, or she was diagnosed to be a hypertensive intrapartum, then it will go up. So this is how I'll be marking the blood pressure and pulse rate for her. Of course, a pulse rate of more than 100 or 110 is going to be problematic. Anything less than 60 is problematic. Similarly, for blood pressure, more than 140 and 90 is going to be an indicator of gestational hypertension or preeclampsia. So this is how I'll be marking the blood pressure and pulse in this partograph. Lastly, unfortunately, just I have to just make the size little lesser of this. Yeah. Now, next, in this segment, I have my temperature. That is, I have to measure the temperature of the female on an hourly basis, which will be written over here. And it is very important in patients with chorioamnionitis to know whether she is having temperatures or any tropical diseases like dengue, malaria, if she has gone in labor in that. And apart from that, her urine examination, especially if she's a preeclamptic, then I'll be doing her urine proteins. I prefer to do them every 4 early, not before that, because it doesn't change that rapidly. So I'll be writing it in the form of +1, 0, trace +1, +2, or +3, or +4, whereas acetone, which is checked, going to be checked, ketones, urine ketones are going to be checked in diabetics, especially over diabetics. That is what I'm going to write here. So +2, +3, or +3, +4, it is going to be written in those forms. On those dipsticks, you get those parameters to be measured. And if she's catheterized, then urine volume. Catheterized, she may be catheterized because of her Maxil therapy that has been given for eclampsia or severe preeclampsia. So urine volume has to be measured. Remember, that she has to have more than 30 ml of urine per hour, or more than 100 ml of urine over the last 4 hours, so that I can continue magnesium sulfate for her. If it is less than that, then I'll have to stop magnesium sulfate and consider some alternative anti-epileptic drug. So this is how my entire partograph is going to look like. Now this was the composite partograph. that you saw. If there are any doubts that you all have on this topic, comment in the comments, and I'll be reading those comments every day and I'll be answering them in the comments immediately. So make sure that you're asking me about your doubts and queries. Okay. So next, next is my modified partograph. Not much of a change. The only change was that they eliminated the most important thing, or the most obsolete thing, I would rather say, that was the latent phase that they've completely eliminated. Apart from that, everything is the same in this modified partograph. The next was a simplified partograph. In this simplified partograph, I'll just enlarge it. You would see that they have eliminated most of the things, and they have just said that you just started uh, from 4 centimeters. Also, by the way, one more thing, this area before the alert zone is zone 1, this is zone 2, and this is zone 3. Even over here, this is zone 1, 2, and 3. Of course, 3 is where you need to do something, 2 is the intermediate zone, and 1 is the safe zone. So over here, they have made these three zones. The pink or the red zone is the one where you take some action, yellow is the intermediate suspicion zone, and one is the safe zone. So in this partograph, the simplified partograph, they have given simple questions which includes the R's, how many R's since ruptured membranes, what was the vaginal bleeding status if she is having bleeding, what is the amniotic fluid color, how many contractions in 10 minutes, what is the fetal heart rate, what is the urine voided, so that you basically don't need to chart anything. You all have to do is write over here the findings. Very simple. And over here as well, you can just chart after every particular examination what is the cervical dilatation status. This is how your simple partograph looks like. Over here, you have to mention everything. It is not as complex as the modified or composite partograph. Then came the most important modification, that happens to be the labor care guide. Now, in the labor care guide of 2020, there were a few significant changes. The first important change in this labor care guide was of 2020. The risk factors had to be mentioned over here. The risk factors had to be mentioned, and also you have to mention when the active labor was initiated. So active labor ka initiation is to be written, and also the labor initiation, that is when the latent labor initiated. So both these columns have to be mentioned separately. Apart from that, the risk factors have to be written over here. Next, one important thing was supportive care that they added. It's a very important aspect that they have added because it was not given any concern. The only concern until now was patient is admitted, just deliver her and that's it. Now they have even given addition to making labor a much more supportive process for, I mean, to make it a much more pleasurable process for the mother, and it shouldn't be a bitter memory for her. For that, the first thing that they've allowed is that a companion and companion from family can be kept with her. Secondly, for pain relief, is she being given pain relief in the form of an epidural analgesia or at least a parenteral analgesia? Are you giving her paracetamol to relieve her pain? Because pain is something that women dread during labor, and pain is something which, in fact, makes them ask for a cesarean section the next time they are in labor because they remember that they had a severe amount of pain. In fact, even in this pregnancy, if the pain is excruciating, she is not going to bear it down, she is not going to let you deliver her, and there can be vaginal lacerations, genital tract trauma that can occur. Next is going to be if she's being given oral fluids, which she can be given clear oral fluids, avoid pulpy and food, but oral fluids, clear oral fluids can be given for her. And finally, what's her posture? Posture is basically, is she mobilized or is she completely supine or is she in a left lateral position? Now, they have also mentioned that there is something called as a alert over here. Alert is basically if any of your answers over here are from the alert points that are mentioned over here, then it's a bad thing and you have to do something about changing it. So if there is a companion, N means no, pain relief, no. So if you get at any point that you are writing that there is no companion at this point, then you have to do something about it and you have to make sure that she has a companion and this answer becomes a yes. So if alert is basically if any of these answers show up in all these boxes, then you have to do something about it. So basically, you cannot have a patient with no pain relief or without any oral fluids. And of course, you cannot be keeping the patient in a SP, that is supine position. Why? Because in supine position, there is iotocaval compression and uterine perfusion is going to be hampered, which is why you cannot have the answer to posture as supine. The patient has to be either in the form of a left lateral, that is LL, or she must be walking, that is mobilized. Next, This was for the supportive care. Now for the baby, they have clear-cut demarcations. Now for the baby, they have mentioned first of all the basic baseline heart rate. The alert points are over here if the fetal heart rate goes at any point below 110 or above 160. Next, now see, for each 1 hour they have made two columns. So half an hour columns have been made for this. Next, if there are any fetal heart rate decelerations, L is a late deceleration. So you can have three types of decelerations: late, early, or variable. Early decelerations are okay, they are because of uterine contractions. Late is because of uterine malperfusion, the fetus is not receiving enough blood, and variable is because of cord compression. Recurrent variable decelerations is indicative of multiple locations where the cord is getting compressed between the baby and the uterus. Isolated बीच बीच में कभी आ रहा है variable decelerations, then you do not need to worry about it. So occasional isolated variable decelerations and early decelerations are okay. Late decelerations are a problem, which is why the alert point over here mentions that late is a bad thing to happen. Next, the amniotic fluid, you have to mention M plus 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 is thick meconium. I've already mentioned +3 is thick meconium or blood stained, which is abruptioplacenta is a bad thing to happen. So you have to look out for that. The fetal position, the alert point should be if the fetus at is P, that is occipito-posterior or occipito-transverse, then you have to do something about it. Caput. What is caput? Caput is caput succedaneum. So whenever the baby is in labor, because of the pelvis, especially the pelvic inlet, once it gets engaged, it presses upon the fetal head. So that part of fetal head that is compressed, it will prevent, the pelvis is going to prevent the lymphatics of the fetal head from sending all the fluid collection back to its body. That is why the fetal head starts getting a swelling. So if this is your fetal head, then your fetal head, if it is pointing downwards, it is going to start getting this swelling, which contains just fluid, edema. This is because the pelvis is not letting the lymphatics send this fluid backward. They are obstructing it at this level. This is called as caput succedaneum. This can be in two forms, +1, +2, or +3, depending on how much of a caput has occurred. So +3 is a bad thing to occur, which is indicative that the baby is just not progressing and there is too much of pressure on the fetal head, and it can be indicative of a cephalopelvic disproportion. Similarly, for molding, we have already spoken, there are three grades of molding, wherein +3 is indicative of overriding of parietal bones, which cannot even be separated on manual touch. So caput +3 and molding +3 is going to be indicative of cephalopelvic disproportion or contracted pelvis, and you need to take the patient for cesarean section. Next, I have the patient who I'll be looking after. So the pulse, if the pulse is less than 60 or more than 120, it's a cause of concern. Her systolic BP, if it is less than 80, that is hypotensive, or more than 140, then it can be gestational hypertension or preeclampsia. Similarly, her diastolic BP, if it is more than 90, then again towards gestational hypertension or preeclampsia. Temperature, she should not be hypothermic because of the air conditioning, and she should not also be hyperthermic because it can be indicative of chorioamnionitis. Similarly, your urine should not have more than 2 plus proteins or 2 plus acetones, because 2 plus or more is going to be indicative of significant ketosis or significant protein urea. Remember, the definition of hypertension in pregnancy or preeclampsia is +2 or more of urine proteins, which is why +2 urine protein or +2 acetate, acetone is indicative of a serious dysfunction of your organs. Next, the total number of contractions less than 2 or more than 5, 2 or less than 2, it is not just less than 2, it is 2 or less than 2. You can see the sign over there is indicative of hypotonia, whereas more than 5, that is 6 or more, is going to be indicative of tachysystole or hyperstimulation. Similarly, the duration should not be less than 20 and should not be more than 60 seconds, that is more than a minute or less than 20 seconds. Next, just take this chart downwards here. Next, I have my labor progress, the labor progress criteria, where in the cervix, I have to plot. Now, this is the most important change that I was talking about, the new understanding of labor that I had mentioned. I'll be talking at the end of the session. Now, you can see that they have mentioned that the first cervical dilatation is at 5 centimeters. So they believe that the latent labor is until 5 centimeters and not 4 centimeters, because the first thing that they have mentioned is 5 centimeters. Now, they have also said that at 5 centimeters, the patient can be there for 6 hours. So if for 6 hours she is at 5 centimeters, it is still okay. Whereas in the definitions that we spoke of in protracted labor, it said that if it is more than 4 hours, with uterine activity or more than 6 hours without uterine activity, then it is protracted labor. Remember, over here it says that at 5 centimeters, you have to anyway wait for at least 6 hours for you to call it protracted labor or for you to do something about it. So they have given a lot more time for the patient to progress. Similarly, these values keep on decreasing. So at 6 centimeter, it is 5, at 7, it is 3, at 8, it is 2.5, and at 9 centimeter, it is 2 hours. So you see that they have mentioned that as the cervical dilatation progresses, the rapidness of it going to the next dilatation also increases. So basically, it more rapidly goes from 8 centimeter to 9 centimeter than how it would go from 5 to 6. This is a very significant change, and they have not assumed that the amount of time taken for a dilatation to go from 4 to 5 is the same as it will take from 8 to 9. This is a great understanding, great evolved understanding of how labor progresses and how uterus contracts. And hence, this has significantly reduced the total number of cesarean sections that would happen. And that's a great new understanding. So, this is something that you have to remember, that they have specified for each dilatation how much of time you can wait before you do something about it. One more important thing is they have also given space for second stage of labor, which none other over here. You see, the second stage has been given place over here, and over here the active first stage. Now, none of the earlier partographs, if you can remember, you see over here there is absolutely no space. यहाँ पे देखो, at 10 centimeters it ends at 10 centimeters. There is no scope for second stage of labor. But over here, they have considered second stage as well, and they have given you time for you to assess the patient in second stage of labor as well. That's a great new addition and something that is very good about labor care guide, that it also looks after second stage arrest and its complications. Next, the same thing about descent as we have already spoken. Then for oxytocin, the same thing as we have discussed earlier, the dose has to be mentioned, how many drops per minute is to be written. Also, if there is any other medicine and IV fluid that is going on. Finally, I have to write my assessment, that what is my assessment? Is it protracted labor, or is there fever, or is the patient looking dehydrated, or what is the problem? So I'll write my assessment. I'll then write my plan for it. I'll write ki oxytocin dena hai, or do a cesarean section, or give the or increase the antihypertensives, because the earlier antihypertensive dose is not controlling the blood pressure. So all these have to be written in the plan, and I will sign my initials over here. My naming Aditya Nimbkar, I'll sign my initial over here, so that we know which doctor has assessed the patient at this point of time. And hence, merely having one look at your chart, at your labor care guide, is going to give you a complete idea of how things stand, and that's a great thing to do. Now there is an example chart that I have taken over here. This is a good example that I have. I'll just enlarge this size. So over here you can see that they have made an example of the labor care guide where they have written the name Mary Jane Williams. She's para 2. Her labor onset was spontaneous, it was not induced. So basically, had you done any prostaglandin induction of labor or Foley's induction, this for this patient it was spontaneous, and her active labor was diagnosed on 6th of July 2020. Next, the rupture of membranes also happened on the same day at 5 a.m. And were there any risk factors? Yes, she had history of stillbirth and anemia in current pregnancy. Similarly, over here they have mentioned all the times, 1 hour interval, and they have shown that there was no companion initially, but eventually that was converted, and then she did get a companion at this point. So at this point, she did have a companion. So again, there was no companion at this point, it was changed, and she had a companion later. Similarly, she had no pain relief, but later on, they took care of that and she got pain relief after that. Similarly, oral fluids were being given at all times. D is she declined to take it, she didn't take it. Apart from that, the posture at every point it is supine, that's a problem. She has to be mobilized, or at least she has to be in the left lateral position. Baseline heart rate is given. The fetal heart rates, you see, no, यहाँ पे एक variable है, but that is okay. Again, no decelerations till here. Over here in second stage, she had early decelerations, which are still okay. Amniotic fluid, it was clear at all times, and आगे जाके it was still clear. Next, the fetal position, it was initially occipital posterior, then it became transverse, and then it became anterior. So basically, the head had completely rotated from occipital posterior to occipital transverse and then anterior. Caput, it was there, but it was only +1 at every point, so the labor did progress. The molding, it was only that at +2, hence the labor progressed. If it would have been +3, it would have not progressed. The pulse was okay at all times. It has been measured every 4 hourly. Similarly, the contractions initially were at 3 contractions per 10 minutes, lasting for 40 seconds. Eventually, they became 3 over 50, and then finally, they were 4 over 50 seconds. Lastly, the cross is going to indicate that the patient has progressed, and then finally P is basically the baby has progressed and then delivered. P is to indicate that the patient is pushing, that she's bearing down actively. Descent has been plotted, oxytocin has been given. Over here they have mentioned that the progress is normal, and finally continuous of monitoring, and finally it has been given. So there were two people who have monitored. One is LA, Dr. LA, and the other one is a GP, Dr. GP. This is how your labor care guide is going to look like. Now, a couple of examples that I would like to show you before we end the session. So I'll show it to you in this one because this is the most common graph that you'll be using in your labor room. So I'll just show my examples in this one. For that, I'll also just delete this one and I'll erase everything. I hope you all have understood everything until now. And if there are any doubts, let me know. You can also send in your doubts to Dr. Kishan, or you can directly contact me, Dr. Aditya. Okay. So the first case that I have, I've just written down a couple of cases. So it's a primary gravida. So I'll just write over here. The name is, let's just say, patient ka name is TN. She is a primary gravida. So pari is going to be 0. The hospital number is, let's say, XYZ. The date of admission, again, let's just assume it is today. And let me just take the date as 15th of uh, September 2025. The time of admission, let's say, is 8 a.m. and the membrane rupture, whatever it is, I'll let you know. So when she has come to me at 8 a.m., she's a primary gravida. Her per abdominal findings include, or they state that the uterus is full term. Her fetal heart rate is 140 beats per minute. It is regular. It is in cephalic presentation, and the activity that she's getting is 2 by 10 by 30. That is two contractions in 10 minutes, each lasting for 30 seconds. Her per vaginal examination findings are suggestive of, now this is by the way at 8 a.m. when she has come to me. So I'll just write over here 8 a.m. Then her per vaginal findings are os is 4 centimeters, the cervix is 40 to 50% effaced, membranes are absent, so amniotomy has already occurred spontaneously, and a station is -1. Remember, -1 has no place for plotting on the abdomen. So, first of all, I'm going to chart her findings. So, when she has come to me, her fetal heart rate they have given is 140 beats per minute. So, I'm going to make a dot at 140 over here. Yeah. So, 140, I've made a dot. Then they have mentioned that the cervical dilatation is 4 centimeters. So, I've made this over here. I'll just use another color pen. So, 4 centimeter at 8 a.m. I've made that. The descent, because it is -1, is why I will not plot it. It is only for 0 to +5. So I've mentioned over here that it is at this position when she has come to me at 8 a.m. The next reassessment, of course, I've mentioned that in my institution, rather in my practice, I prefer to do the assessment after 4 hours. When she has come to me, the uterine activity has been 2 by 10 by 30. So for 2 by 10 by 30, I'm going to make it like this. Two contractions, each lasting for 30 seconds. What do I do next? The membranes are absent, so the amniotic fluid is clear. So I'm going to write over here as C. And the molding that I could feel was not there, so it was 0. This is how I have written, and the pulse, maternal pulse, was in the normal range. It was 70, and the BP was also in the normal range. This is how I have written. She was having a temperature of 37 degree. Her urine protein and all was not checked because she was not a hypertensive. These were my initial assessments. Then I kept assessing her. The fetal heart rate was assessed regularly. It was consistently in the normal range. I assessed it, and this is at 9, 10, 11, and 12. I decided to assess her now at 12 p.m. after 4 hours. So after 4 hours, her per vaginal findings were her per abdominal findings were after 4 hours at 12 p.m. Her per abdominal findings were same full term uterus, FHR was 150 beats per minute. The uterine activity was 4 by 10 by 50 at this point, and her per vaginal examination showed the os was 10 centimeters dilated, the cervix was fully effaced, the station was at +4, and finally the membranes were of course absent, pelvis was adequate. So in this scenario, she has reached full dilatation. So I have measured the heart rate till 12 o'clock over here till this point. It was always normal. So it was always normal. Now she has reached 10 centimeters at 12. So this is the chart where I plot it. And the descent is at +4 at this point over here. So the labor has progressed in this direction and it has not crossed the alert line, whereas the descent has also come down. The activity, I have monitored it regularly, was initially like this, but then it started becoming a lot more. So I made solid lines like this. And by the time it was 12 p.m., she had an activity of 4 by 10 by 10. So I'm going to make it 4 by 10 by 30 to 40. So adequate uterine activity has been depicted for her. Oxytocin was not required. The BP was measured in the normal range, and this is how she has progressed. This impression is going to be normal labor. Now let me make a variation. Everything was the same when she came to me, but everything was same. I'm just going to show you the cervical dilatation chart. She came to me at the same findings, but now at 12 p.m. the findings, her per vaginal findings were different. The per vaginal findings were her os was 6 centimeters dilated, the station was at 0, and rest all findings were same. So at 6 centimeters, this was at 8 a.m., this was at 9, 10, 11, and 12. At this point, it was just 6 centimeters. So it had crossed the alert line. I decided to become a lot more suspicious because it had crossed the alert line. And I decided to start the patient on. I called a senior obstetrician. The senior obstetrician, here being me myself, decided ki she's not progressing. Let me do something. Either I can wait for action line or I can just start the patient on oxytocin. So I started the patient on oxytocin, and by 4 p.m. she became 10 centimeters and she delivered. So by 4 p.m. she reached 10 centimeters. In fact, even before 4 centimeters, she reached it at 2 p.m. itself because I started the patient on oxytocin. So 1 and 2. So at this point, she reached 10 centimeters and she progressed very well and she delivered. So the action line was never crossed. This was how that intervention helped me at this point. The next case is when this progression didn't happen and the patient, even at 4 p.m., stayed at 6 centimeter itself. Even at 4 p.m., she stayed at 6 centimeter itself, despite starting oxytocin. So this was 3 and this was 4. So at 4 p.m., it was still 6 centimeters. And basically, there is a flat lining of my partograph over here. This flat lining is going to indicate that my patient has crossed the action line, and now I have to give the impression of, in the second case, the impression was of protracted labor, for which I started the patient on oxytocin, whereas over here now, since it has crossed the action line, my impression for this case is going to be arrest of labor. So arrest of labor is going to be indicative of my decision to go for emergency cesarean section. And this is how I have to keep an eye on the alert and action line through various case examples. A normal chart is going to look like this. Latent labor, if prolonged, is going to look like this if you're using the composite graph. If you're not using the composite graph, then your protracted labor is going to look like this. Whereas your arrest is going to always look like this. Of course, it cannot go below because your dilatation cannot reduce. But if this reaches 10 centimeters, then it was just this part was prolonged labor, whereas this was arrest of labor. So that is how your various charts look like. Whereas this S-shaped curve, if it is looking like this, then you have to call it normal labor. And that is how you will be charting a graph. You have to do a per vaginal examination, in my opinion, every 4 hours. But if your institution is asking you to do it every 2 hourly, then you have to just plot it every 2 hourly. So in this case, it would have been you charting it over here as well, a 2 hourly charting. Okay, but in my institution, we and in my practice, I prefer to avoid. Even ACOG recommends do it only 4 hourly because you will unnecessarily introduce outer microbes into the vagina. So avoid per vaginal examinations, especially once the membranes have ruptured. And this is how you will be using your graph, and you'll be using it to take action once it goes into the zone 3. So that is it from the session on Partograph. I hope you all liked it. If you all have any comments, do let me know. I'll solve them. If you like the session, do give me your feedbacks. If you want me to take more sessions, I and Dr. Kishan will decide on which sessions that you all want. Until then, keep watching the White Army.